Hello friends, hello teachers. Today we are going to talk about volume regulation. The members of the group are myself, Mateo Yumikinga, Francesca Sarmiento, Carla Silva, Dali Silva, and Pedro Torres.
Good morning. I am going to talk about the efficacy of the regulation of the fluid volume and the extracellular fluid volume. Yeah. A small change in the blood volume causes a change in the cardiac output. Second, a change in the cardiac output causes a change in the blood pressure. A small change in the blood pressure causes a change in US. Yeah, setting of the control mechanics, low blood pressure provocates the fluid retention in the kidneys. And in the anomalies is the volume of the in the erythrocyte cause the flash volume will change because the blood volume will be balanced. The distribution of the extracellular fluid between the interstitial space and the vascular system. Yeah. First, in the rises capillary factors, these factors. First, the rise capillary hydrostatic pressure. Second, decline pressure with the plant's colosmatics rises of increment in the greases capillary permeability and obstruction of lymph nodes. Yeah, loss of the 20 or 30 the liquids of liquid interstitium, and loss of the 30 and 50 the rises the liquid extracellular in the loss liquid interstitium.
And now I'm going to talk about the nervous and hormonal factors that increase the efficacy on renal body fluid feedback control. Well, nervous and hormonal factors influence in GFR, tubular reabsorption, and renal expression of salt and water. And these often act in conjunction with mechanisms of pressure natriuresis and pressure diuresis, making them more effective. If we see a high sodium and a low potassium diet, we are going to see hypertension that leads to a kidney disease or a cardiovascularity, morbidity, and mortality. If we see a high potassium diet, we have natriuresis, vascular effects, and renal protective effects. These systems help in minimizing the change in blood volume, extracellular fluid volume, and blood pressure that occur in response to daily challenges. Like, even if we just walk, there is a change in blood pressure. And there are other things that influence this, like lifting, running, or even just getting mad at someone. Now we have the sympathetic nervous system controls with renal expression, arterial baroreceptors, and low pressure stress receptors and reflexes. The kidneys receive extensive sympathetic innervation. It changes all the activity in sympathetic and can alter renal excretion of sodium and water, as well as regulation of extracellular fluid volume in some conditions. When we see a high volume in some in our body, the sympathetic nerves are going to have an action in this. We have a lot of water, so we need to excrete this. Also liberating sodium, potassium, and hydrogen. The several efforts are constriction of renal arterioles, which decrease GFR if sympathetic activation is severe, increases tubular reabsorption of salt and water, and stimulation of renin release, ING2, and aldosterone formation.
Okay, I'm going to talk about the role of the angiotensin II in the control of renal excretion. First, we need to know that the angiotensin II is one of the best controllers in the sodium excretion. The changes in sodium ingestion are accompanied by reciprocal changes in angiotensin II production. This is because we need to maintain a balance in the sodium in the body. First, we have one case when we have a lot of ingestion of sodium. We are going to have a less angiotensin production, then less sodium reabsorption, and we are going to excrete a lot of sodium. This is going to reduce the blood pressure to balance it. And then if we have a big sodium ingestion, we are going to have when we have a less sodium ingestion, we are going to have a higher angiotensin II production, a higher sodium absorption, and less sodium expression. This is going to increase the blood pressure and equalize the pressure. This acts as a regulator of sodium excretion and also is an amplifier of the pressure natriuresis to create the blood pressure and body fluid volume status. Yeah. Then the role of the aldosterone. Its function is to absorb sodium and water and secretes a condition to excrete it in the organ. First, when we have a sodium intake low, we are going to have a higher aldosterone production to absorb more sodium and to try to excrete a little bit sodium. Then, in the other hand, if we have a higher sodium intake, we are going to have a less aldosterone production, and we will absorb less sodium, and we are going to excrete more sodium. It also collaborates with the mechanism of pressure natriuresis in maintaining sodium balance. During the variation in salvages, it is relational with the angiotensin II. The role of the ADH the ADH or antidiuretic hormone it allows the kidney to form a small volume of concentrated urine while excreting normal amounts of salt in it. When we have a low level of water, we are going to have more production of ADH, and we are going to absorb more water. It reduces the extracellular volume of blood pressure reduction. If the effects of the ADH is blocked with a drug or something like that, we are going to have less production of ADH and less water reabsorption. And it is to produce less in extracellular volume and blood pressure reduction. And then other case is when we have a higher extracellular volume, we are going to have a less production of ADH to have a less water absorption to maintain the balance. And finally, role of the antidiuretic. 15. Here we have that it causes three acts that are causes small increases in glomerular filtration, decreases the renin secretion and angiotensin II formation, and reduce sodium absorption. Those three functions are going to higher the excretion of water and salt, and it compensates the excessive blood pressure and volume. The excessive production or complete lack of this are not going to have an important or major changes in blood volume because these are going to be regulated by the blood pressure and natriuresis pressure.
I am going to talk about disorders that result in a large increases blood volume and extracellular fluid volume. This happens when there are abnormal conditions that increase volume of the volume. For example, is heart disease. The heart failure increase volume between and 15%, and extracellular fluid up to 100%. And heart failure is serious, and the body will can fluid retention until blood pressures and restore on the patient has circulatory congestion and pulmonary edema.
I'm going to talk about the increased circulation capacity. Bueno, the increased capacity chance that aerovascular capacity will increase blood volume. Less pressure. The less pressure random retent of salt and water. In the blood volume is the extra capacity. Cardiac output and the blood pressure are reduced. One example is in the pregnancy. The woman increases the flow of blood into the 15 and 25%. Disorders resulting in a great increase in the extracellular fluid with the reduced blood volume. The extracellular fluid is really increased, but sometimes the blood count remains normal or is even something reduced. They are initiated with a lot of fluid and the proteins into the interstitium. The kidney retains salt and water to try the normalized blood volume. The extra liquid lives in the interstitium. With the liquid stay in the interstitium, causing edema.
Okay, and now I'm going talking about the disorders. First, this is a nephrotic syndrome. In this syndrome, loss the plasma proteins in the urine and renal retention of sodium. It is important cause of edema. For example, in this leg, have edema. And the glomerular capillaries lose large amount of protein during in filter and urine, and between 30 and 15 grams of the plasma proteins are lost in the third day, and this causes the plasma protein concentration to fall to less than 1/3 of normal levels of plasma. For this, the plasma concentration is less, and the colloidosmotic pressure of the plasma is less. And for the capillaries, drop of the body will filter large amount of the fluids, and this cause is the enema, and the plasma volume is less. And the kidney will retain sodium and water until the plasma volume normalizes. And For this, then massive renal fluid retention until extracellular edema appears. Another disorder is the hepatic cirrhosis. In this, decreased hepatic synthesis of the plasma proteins and renal retention of the sodium. And in this case, less the reduction in the plasma concentration and produce the destruction of the hepatocytes and less the ability of the liver to synthesize the sufficient plasma proteins, and it is complained by large amounts of the fibers in the liver, and the capillary pressure is high and contributes to leaks and fluid and protein into period cavity, and the kidneys continue to lose the water on until the plasma volume and the artery pressure is normalized. This is the bibliographic reference. Thank you.